Hello, everyone. My name is Yoav Keinan, and I am the Scientific Director of the National Collaborating Center for Infectious Diseases. The NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for public health planning and policy, and is supporting the agency with knowledge translation during COVID-19 pandemic response. I would like to acknowledge that the NCCID is located at the University of Manitoba on the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and the homeland of the Métis Nation. I welcome you to the Public Health Agency of Canada webinar on health for healthcare providers. But before we start, I would like to start with some housekeeping items. The webinar is run through Zoom. If you have any problems with Zoom, please contact us through email at nccid@umanitoba.ca. For the questions and answer session after the presentation, we will be using the Q&A tab. Please submit your question to our experts there. You can like questions that other people have posted, and that will help to push those up in the priority. We will attempt to answer as many of the questions as we can, but we might not get to all of them. The speakers and hosts will use the chat tab for extra communication to attendees and keep an eye on that tab as well. The chat is disabled for participants, however. After the webinar, the recording of the presentations will be available shortly on nsccid.ca. Today's webinar focuses on COVID-19 vaccine and emerging issues. And today our focus is delayed injection site reactions. The webinar will begin with a presentation by Dr. Elisa Abrams and Nushin Ahmadipur. Following the presentation, there will be time for questions for our presenters and panelists. Let me introduce the presenters. Dr. Elisa Abrams is a pediatric allergist and assistant professor at the Department of Pediatrics in the section of allergy at the University of Manitoba. She's an associate member of the Department of Pediatrics Division of Allergy at University of British Columbia and is the president of Allergy Section of Canadian Pediatric Society and head of the Anaphylaxis and Food Allergy Section of Canadian Society of Allergy and Clinical Immunology. Nushin Ahmadipur, MD, MSc, is a senior epidemiologist and head of Canadian Adverse Event Following Immunization Surveillance System at the Vaccine Safety Section of Public Health Agency of Canada. She has been working with vaccine safety since 2002 and has co-chaired the Vaccine Vigilance Working Group between 2006 and 2016. And currently she supervises the data processing and coding team and assists the team members with any other COVID-19 related surveillance activities. I now invite our presenters to begin.
Hello, everybody. My name is Dr. Elisa Abrams, and we're going to get started on this webinar. So I will be presenting in collaboration with Dr. Nushin Ahmadipur, and then at the end we will have a Q&A. And as already has been mentioned, this is really a webinar that's focused on delayed injection site reactions following administration, in particular, of the mRNA COVID-19 vaccines. These are our conflicts, and none of us have any significant conflicts of interest to declare. So the objectives are to provide an overview of these delayed local injection site reactions, in particular following administration of the mRNA COVID-19 vaccines. We're going to go through data from the Moderna clinical trial. We're also going to go through data from the Canadian Adverse Events Following Immunization Surveillance System. We're going to look at the features of these reactions, the management of these reactions, and provide some guidance on distinguishing these delayed local injection site reactions from other local reactions, such as cellulitis. And this is the outline. It's quite similar. We're going to start looking at injection site reactions overall. We're then going to get into data from the Canadian Adverse Event Following Immunization Surveillance System. Then we're going to look at data from the Moderna clinical trial. We're going to talk about distinguishing a delayed injection site reaction from cellulitis. And then we are going to talk about management of a delayed injection site reaction. So we wanted to start a little bit just looking at local reactions in general, and just contextualizing that injection site reactions, local reactions after vaccination are exceptionally common, one of the most common adverse events that are reported. In general, they're usually fairly immediate. So they occur within a few hours, they go away quickly, they're usually mild to moderate. They include symptoms such as pain in the area of the vaccination, swelling, redness, sometimes itchiness, and they're part of the normal immune response of the body. In fact, in the Moderna study, and you're going to see a slide on this later, about 84% of participants had a local reaction in general. Now, it's also interesting that delayed local reactions are not new. They have been described in the past with other vaccines. These occur within hours to days. They can be delayed weeks. There are various different pathophysiologies. So for example, for the tetanus vaccine, there is a delayed reaction that's an ARTHIS or an immune complex type reaction. And these are self-limited and they do not contraindicate future vaccination doses. Now, with the mRNA vaccines, in particular Moderna, delayed local reactions are being described based on one patient. So this is very early. It may be T-cell mediated hypersensitivity, although the underlying pathophysiology still remains to be determined. The big take-home points, and we're going to go through this again, are that these local reactions do not contraindicate administration of future vaccine doses, and they do not increase the risk of anaphylaxis. And now I'm going to hand it over to my colleague, Dr. Ahmadpour.
Thank you, Elisa. I hope you can all hear me. Hi, everyone. My name is Nushin Ahmadpour. I will present a summary of the reports of vaccination site reactions submitted to the Canadian Adverse Events Following Immunization Database, or CAFIS, for the period up to February 23rd. The first slide presents a distribution of reports by vaccine and age groups. For reports with at least one vaccination site reaction, we refer to them as local reactions, injection site reactions. And so the first pie at the top shows that 493 or 75% of these reports were following Moderna vaccine, and 165 or 25% following the Pfizer product. And using the doses distributed vaccines, the reporting rate was calculated as 95 per 100,000 doses of Moderna and 12 per 100,000 doses of Pfizer vaccine. The smaller pies at the bottom show the reports by age group of vaccine. The proportion of reports for the age group 16 to 49 years was 45% for Moderna, 67% following Pfizer. For the age group of 50 to 64 years, it was 20% after Moderna and 30% after Pfizer. And finally, for the age group of 65 years and over, it was 35% following Moderna and only 2% following Pfizer. Please note that these data are based on the count of submitted reports to CAFIS. Since we don't have the number of doses administered by age, we were not able to calculate the reporting rates, so we are not drawing any conclusions. Going to next slide. Slide number 7. One slide before that, please. Yes, thank you. So in this slide, we are showing the distribution of local reactions. Now going back to the table that shows the time to onset. One slide before that's showing. So We are showing in the following slide the distribution of local reactions by vaccine and time to onset. So far, local reactions have mostly been reported following Moderna vaccine, both in numbers and reporting rate. When they compare these events by the onset in 3 groups of 0 to 3 days, in between 3 and 8 days, and 8 and plus days, we saw the most of this reaction occurred with 3 days after receipt of Pfizer vaccine and after 8 and plus days following Moderna vaccine. At time of report, outcome of local reactions following Moderna vaccine was comparable among the 3 groups of onset times. And for the delayed onset, when we refer to delayed onset, we're talking about 8 and more days following vaccination. In the group of Moderna vaccine, the outcome was reported as 41% as fully recovered, 53% as not yet recovered at time of report, and in 6% it was either not indicated or reported as unknown. So we stay on this slide. As mentioned previously and shown in this table, most local reactions following Moderna vaccine were experienced 8 days or longer after receipt of the vaccine. Main symptoms in the delayed onset group in the red box following Moderna vaccine were erythema, pain, swelling, and warmth. Some patients had rash, urticaria, pruritus, and induration, and there were no reports of extensive limb swelling. Several of these cases, about 42 of them, were managed as cellulitis. Going to the next slide, please. That's actually the slide that I presented before, showing the time to onset and the frequency of reports following each one of the vaccines. So next slide, and the one after that is for Pfizer vaccination site reactions, please. Yes, that's the one. So following the Pfizer vaccine, over 70% of local reactions were experienced within 3 days of vaccination. And among the delayed onset group, in the red box again, main symptoms were rash, pruritus, erythema. There were some reports of pain and extensive limb swelling, and 1 report of vaccination site paresthesia. As with Moderna vaccine, some cases were managed as cellulitis. So this was my last slide. Thank you, everyone, for listening. Back to you, Elisa.
Thank you, everyone. So this is data from the Moderna trial, and this looks at solicited adverse events within the first 7 days after either dose 1 or dose 2 of the vaccine. And what you can see when you look at local events is that these are exceptionally common, occurred in over 80% of trial participants overall. The majority were mild to moderate. The most common symptom was pain, followed by, you can see, occasionally erythema, swelling, lymphadenopathy, at or around the site of the injection. And once again, these are not harmful and not a contraindication for future vaccination. Now, we're also seeing, as we've already talked about, these delayed local reactions. And these were actually described within the Moderna clinical trial. In the clinical trial itself, they described these reactions as happening on or after day 8 and resolving within approximately 4 to 5 days. And they say that they occurred in about 0.8% of vaccine recipients with the first dose, much lower with the second dose, about 0.2% of vaccine recipients with the second dose, but they don't further characterize them in any significant way. Now, more recently, there has been a case series of 12 patients. So this is still small numbers, but it's the biggest that we have, also looking at these delayed local reactions. They provide a wider time frame. So the median onset is still day 8, but range day 4 to day 11. They resolve within 6 days, but range day 2 to day 11. Symptoms include pain, erythema, swelling, induration, itching, and there were systemic adverse events in a few patients. So one had a very low-grade fever, some had myalgias, chills, headaches. The big important thing to me from this case series is what they did after these delayed local reactions. So all 12 participants, all 12 people who had these reactions were told you should get the second dose of the Moderna vaccination. All of them did. Only half had a delayed reaction again. So half had no recurrence. Of the half that had a recurrence, about half of those were similar and about half of those were more mild. So the recurrence, if it occurred, was either milder or the same. It was not more severe, and there were no immediate or life-threatening reactions. And here are some pictures of these local reactions, these delayed local reactions. Some of the pictures were taken in a mirror, so it can be hard to tell, which way is which, but you can see in particular patient 5 and patient 6, they actually had cutaneous symptoms elsewhere. So patient 5 had a palmar rash. Patient 6 had urticarial plaques on the elbow. But what you can see, I like patient 1. That's a very nice picture to me of this sort of red indurated swelling in the area of the vaccine. And here are the other patients. You can see for many, there was no recurrence with the second dose. For some, there was no recurrence, but there was mild erythema in the area. For some, there was a recurrence. And of those where there was a recurrence, for some, it was milder. For some, it was quite similar. Now, distinguishing a delayed local reaction from cellulitis. This can be a little bit difficult to do. So we wanted to spend a minute or two giving whatever guidance we could here. There are a few ways to potentially differentiate them. One of the main ones is that in general, if you have cellulitis, you tend to be systemically unwell. So fevers, chills, myalgias, cellulitis tends to happen faster, onset sort of day 3 to 5. Cellulitis after vaccination, while described, would also be exceptionally rare. Now, what makes this a little bit complicated is that for a few people who have had these delayed local reactions, they have had mild systemic symptoms, which can make it difficult on occasion to differentiate. But these are some ways that you can potentially do it. If there are no systemic symptoms, if it's a swelling, induration, erythema in the area of the vaccine, you could monitor and then only treat if you're noticing systemic symptoms or toxicity or worsening of symptoms over time. Management. The big one is reassurance in terms of future risks. So we've already talked about this a little bit. The risk of a systemic reaction is no higher than the general population. These people are not at risk of a more systemic reaction because they've had a local reaction. And in fact, even if they get the second dose, the risk of a local reaction is actually lower. So reassurance in general. You can do conservative measures such as ice packs, cold compresses. You can consider analgesics. In terms of the type of analgesic, it doesn't really matter. The only thing to know is that if you use non-steroidal anti-inflammatories like ibuprofen, there is a risk of hives. And so if you use those and there are hives, just bear in mind that those analgesics have been used. Antihistamines can be considered. In general, avoid systemic steroids. Topical steroids can absolutely be used. And then, of course, monitor the evolution of signs and symptoms. Make sure it's not getting worse. Make sure there are no systemic symptoms. So key points. Delayed local reactions are occurring. They're still relatively rare. They are not serious. They are self-resolving. They do not preclude future vaccination. They do not increase the risk for anaphylaxis with future vaccination, and they are less common with the second dose than they are with the first dose. Inform vaccinated patients that these reactions can occur, but the big take home is that reassure them, especially those patients who have experienced it, that the reaction is benign. If you would like, the Canadian Immunization Guide has a section on vaccine safety, and this goes through definitions of adverse events following immunization and additional general information. You may also wish to subscribe for NACI publications and updates to the Canadian Immunization Guide. You can do that through the website. In addition, there is a toolkit for healthcare providers, canada.ca/coronavirus. And with that, we just wanted to thank the Public Health Agency of Canada, Vaccine Safety Section, the NACI Vaccine Safety Working Group, and the National Collaborating Center for Infectious Disease.
Thank you very much, Lisa and Nushin. For the next portion of Q&A for this webinar, I would like to invite Jocelyn Zafak and Dr. Gina Lacuesta. Jocelyn Zafak is a senior epidemiologist at the Public Health Agency of Canada working on COVID-19 vaccine safety. She's a lecturer in Department of Social and Preventive Medicine at Laval University and has worked on immunization and infectious diseases at CHU, at the Quebec University Laval Research Center. Welcome. And Gina Lacuesta, who is an allergist and clinical immunologist in practice since 2002, a graduate of Memorial University in Newfoundland, and completed internal medicine in Saskatchewan and allergy and clinical immunology in University of Western Ontario. She's currently an assistant professor at Dalhousie University and has a private practice in allergy in Halifax. She's currently working at Nova Scotia COVID vaccine expert panel and within the NACI Vaccine Safety Working Group. Thank you all for joining. Let's start with some of the questions from the chat. So there's one question that raised to the top with multiple votes. Have any of the delayed reactions included ulceration and or tissue breakdown and disruption? I'll direct that to all of the panelists.
I can take that question. Certainly, we've seen these referrals come for a lot of patients in Nova Scotia. I see all the adverse reactions that have come that way, and certainly in the trials, these reactions resolve fairly easily with symptomatic treatment. There's no resulting tissue breakdown or ulceration. There's really no serious outcomes like that. They've all resolved. Certainly in the reports that we've gotten through the APHIS in Canada, we don't have the final data on the resolution. They were just reported when they're happening, but I can speak from personal experience. What we've seen in Nova Scotia, they do seem to resolve quite easily with symptomatic treatment.
Thank you. Any of the other panelists seen additional information on ulceration?
No, I can just add that in the literature, it's exactly the same, and it hasn't really been described at all.
Thank you very much. The second question that has received multiple points of interest, what happens when you take non-steroidal anti-inflammatories? What is the effect on those delayed reactions that you described? And maybe Lisa?
Sure. So in general, and I'd certainly be interested in the panelists as a whole recommendations here as well, because this is a new space, of course. I would only recommend analgesia for symptomatic control. So if they have a delayed local reaction and it's quite painful, consider adding analgesia of some kind, whether it's acetaminophen or ibuprofen. That really doesn't matter. The only thing to know is that rarely non-steroidals can cause a hive-like reaction. And so if that occurs, just to bear in mind that a non-steroidal was used.
I would add, we can all say we have our own favorite analgesic medications, and some people will swear by ibuprofen or other NSAIDs, and some will swear and say acetaminophen does nothing for them. I agree with Elisa. There is a rare chance that they can induce hives. So there will be some sorting out if that happens. But I think unless that patient has a known urticarial response to NSAIDs, there's no reason why it would be contraindicated. If that's their favorite analgesia of choice, they should use it.
Excellent, thank you. So the next question, again from the Q&A block, is for reactions that were managed for cellulitis, how many of those are actually that? What are the chances that those are just mislabeled as cellulitis?
I can start with the answer to that question. It's hard to know for sure if we weren't there assessing the patient, but I would think the likelihood of these truly being cellulitis is quite rare. You know, we see this as allergists all the time on our patients with other injections where they get large local inflammatory reactions. The chances of getting cellulitis from an intramuscular vaccine is highly, highly unlikely. There is a much higher chance that this is a local inflammatory delay type reaction that we've been describing. But I can appreciate that sometimes when you're there, it is hard to make that difference. Elisa did mention that with cellulitis, you look for systemic features, you know, fevers, malaise, myalgias, but they can also be reported with these delayed type reactions as well. So sometimes it's really difficult to tell the difference, but I would err on the side that it's probably more likely to be a delayed injection type reaction such as this, especially if it happens 8 days and longer. A cellulitis should happen quicker.
Thanks. And the problem obviously with cellulitis is that we frequently don't have any diagnostic test for it and treat it empirically, and it may have been overtreated in some of those. Great. Is there any data from clinical trials about the incidence of delayed reactions and how they change with the different age groups? Is it more common or less common in elderly, and what are some of the observations? Maybe Nushin?
Well, I can speak on that. I don't know if Nushin is froze, like she's not moving on my screen. So it was presented in one of the slides, like in the Moderna clinical trial where they were described. It occurred in 0.8% of patients after dose 1 and 0.2% after dose 2. But they didn't break it down based on the various age groups. So these data represent what was observed in all the patients in the clinical trial. But from what we've seen based on the surveillance data, we do not expect to have an increased incident in older patients.
Thank you. Another question that is of interest is, do you have any sense of what is the pathophysiology of the reactions, what they might be attributed to? And this one is directed to Dr. Abrams, but all panelists are obviously welcome to add to that.
Don't know is the short answer. In the case series, they did do a biopsy on one patient, and they thought that the clinical features, the features on the biopsy may be consistent with a delayed T-cell mediated reaction, but it's way too early to tell. I think the big thing, at least for me, would be that it doesn't seem to be consistent with an IgE mediated reaction, and it doesn't seem to increase the risk of anaphylaxis, which is often what people are quite concerned about. But in terms of exactly what's going on here, it's a little bit too early to know for sure.
And in terms of what are the antigens that are stimulating this response, do you have any information about the role of PEG in that, or can you speculate?
So I can speculate a bit, and then I might tag team Gina on this as well. It doesn't seem to fit just in terms of time frame. So the concern with PEG has been more these immediate, more systemic reactions, because PEG has, once again, very rarely, but has been described in the literature as potentially causing IgE-mediated systemic reactions. And so PEG has been implicated as a potential etiologic agent, excipient agent in the more immediate systemic reactions. To my knowledge, there has been no such speculation with respect to these delayed local reactions.
Gina?
I agree with Elisa. It's far too early to say. And honestly, I don't know that anybody's really going to do a whole lot of research into describing exactly what that antigen is, considering these are self-limited, though uncomfortable, but not serious reactions. This may simply be just normal reactogenicity of these vaccines, not necessarily antigenic from something sinister or excipients in the vaccine, but it's far too early to say.
Okay, and then there's a question that has been very popular. It's not directly related to the Moderna or Pfizer vaccines, but do you have some sense of the comparison with the initial reports from the AstraZeneca vaccine in terms of delayed or other local reactions?
Well, I can speak to that. The incidence of local reactions in general, that both the immediate and delayed one with the AstraZeneca vaccine was comparable with what we had with the 2 mRNA COVID-19 vaccines. And specifically in the AstraZeneca vaccine, they didn't describe any delayed local reactions. So in terms of local reactions, the safety profile is the same.
Okay, any of the other panelists want to comment on this question?
I don't have anything else to add.
Okie doke. So we'll move to the next question. Is there any evidence that or any correlation between the strength of the local reaction or the delayed reaction and the protection that the vaccine offers? So any measures of success of the vaccine or antibody titers or any other markers of how well the vaccine has worked?
I don't think we have any data to answer that question. I think it's definitely a speculation, and we like to reassure ourselves and our patients that, you know, if they have these local reactions, that their immune system is working, and that's reassuring. But then the converse, you have to worry about those people who don't get the reactions. They worry, is my immune system reacting to this? So I think at this point, we really can't concretely answer that question at all.
And I would, I was just going to add, I completely agree with Gina. And once again, just to contextualize this, these reactions are happening in less than 1% of the population. And we know that the efficacy based on the trials is exceptionally good. So it will be very difficult to make any speculations about that.
Thank you very much. So a question that was sent for, and I will ask that for Gina to respond first. Should we tell our patients to take medications prophylactically before the first dose, before the second dose, only the first dose, to avoid or to try to decrease those reactions?
So I wouldn't necessarily recommend that its prophylactic use is necessary, and there's certainly no evidence to show that that's going to decrease your chances of getting these localized or delayed reactions. Certainly with symptomatic antihistamines, we want to avoid using these prophylactically, as you don't want to mask any early signs of anaphylaxis that we might use to judge whether or not someone's having a serious reaction to these vaccines. But I think as soon as somebody is symptomatic with this, the earlier they start these symptomatic controls, as Elisa said in her talk, analgesics, antihistamines for itching and burning, topical steroids if needed, the sooner they can start and you can get that patient comfortable is ideal. I think the more the patients suffer, I worry that message is getting out there, and it can contribute to vaccine hesitancy, and we don't want that. So I think as soon as these patients develop these symptoms, to start these treatments ASAP and to advise them of that. But I don't think prophylaxis is necessary.
Thank you. And maybe with that, I'll ask a follow-up and direct it to Nushin. Those reactions that we just talked about, are they more frequent after the first or second dose? Do you have any? And what are some of the differences that are seen between Moderna and Pfizer vaccine? Again, to summarize, some of it has been shown in slides already.
Yes. We have based on the data that we have in cases, about 93% were following dose 1 of Moderna and 76% after dose 1 of Pfizer. However, we don't know how many doses, how many of first doses went into the arms and how many of the second doses. So we don't have a denominator to calculate the rates again. So maybe later on, when a larger number of people receive their second dose of both vaccines, we can repeat the analysis and look at the results. But so far, based on the data that we have, majority were reported following the second dose, following the first dose. Again, keep in mind that we are early in the campaign yet.
Thanks. And then just another caution about those rates. There also the Moderna and Pfizer have been used in different populations, and that may change rates of reactions as well. So just to
True,
caution.
that is correct as well.
Very good. The next question from our chat questions is regarding the reporting. So maybe Jocelyn, about what are we expected to report? What degree of side effects do you expect reported in, so we can keep track of very common reactions?
Okay, I will start and then Nushin can complete if needed. So what I would say is that usually you're different either at the national level or at the province or territorial level. Usually the surveillance system will give you the criteria of the APHIS they would want you to report. So if these delayed reactions in terms of severity fit the criteria for reporting, you should report. And in case you are doubting if they are eligible or not, what I would recommend is for you to report, and at the level of the surveillance system, they are going to decide if to keep it or not. So.
Thank you, Nushin.
Yes. I think that was a perfect response. I just would like to add, since the online user guide for reporting has a page at the end of the guide indicating the temporal criteria for specific adverse events following inactivated vaccines versus live vaccines. And what is indicated there is encouraging to report, not encouraging to report, but specifying the timelines for local reactions happening within 3 days and for cellulitis within 7 days. So that has been one of the issues with a lot of provinces, that it doesn't fall, like delayed reactions after 8 days doesn't fall within the temporal criteria. So this presentation, and we also presented this information to provinces and territories to help them in making decisions in reporting. So yes, these reactions are happening outside the temporal criteria that has been specified in the user guide.
Thank you very much. Do you have any sense of if the vaccine reactions are more common if administered at the same side or the other arm? Is there boosting of the response, so to speak, if both doses are administered on the same side? Sorry.
Well, personally, I do not have any information specifically about that. And based on what we know, I wouldn't say that administering it at the same site would make any difference. So usually what we would recommend is to administer it on the arm the patient is not using regularly. Because if the person is right-handed and you administer and then there's the pain, well, it will prevent the patient from going on with the daily activities. So usually we will recommend you to administer on the arm the patient uses less.
Any other panelists thoughts on same side, other side? Does it make any difference?
So in the case series, now bearing in mind this was 12 patients, right? So we really don't have a lot of data here. Some people had the same side, some people had the alternate side when they got the second dose. It didn't seem to really make a difference, but once again, just to contextualize, this is rare, so a lot of this so far is not really known yet.
Thank you very much. In terms of recommendations, what antihistamines, or are there specific ones that you should choose, or they're all created equal?
I can take that, Elisa. I'm sure we're both jumping at the bit to try and answer that question. So we really want to try and stay away from the sedating antihistamines, such as Old Faithful Benadryl that everybody loves, and you know, it's the first thing they grab off the pharmacy. But we really try to avoid those, as there's a lot of side effects, namely sedation in the older folks interacting with other medications where it may cause sedation as well. The newer non-sedating second generation antihistamines are what are recommended. And especially sometimes if they're quite symptomatic, we will recommend that these antihistamines can be updosed. And if you updose Benadryl, the rate of sedation is even higher. And it is actually a myth that Benadryl or diphenhydramine works more effectively, works more faster than these newer ones. They are equal in terms of effectiveness. The newer ones last longer and give better relief. So I would typically recommend, I will say the over-the-counter names, so Reactine or Cetirizine, Arius or Desloratadine, Allegra or Fexofenadine. Those are all readily available over the counter for the patients.
Thank you very much. So non-sedating and second generation. Perfect. In terms of, maybe we'll continue with you and about the steroids, any specific steroids that you recommend for the topical use that you mentioned earlier?
Again, we want to try to avoid systemic steroids for a multitude of reasons. We don't want to blunt the response to the vaccine. And as well, there are short-term side effects from systemic steroids that probably aren't necessary to take on the risk for something like this. Topical steroids can be helpful. I think at least hydrocortisone 1%, so a low or moderate potency. Practitioners often have their favorite moderate potency topical steroids, so something like mometasone or betamethasone would be fine.
Thank you. Okay, you mentioned that, and I think this question is to Nushin. You mentioned that about 50% of the delayed reactions after Moderna vaccine have not yet recovered. Are they more severe, or how do they compare in severity in the different age groups, the ones that have not recovered? Can you comment on that?
Actually, not necessarily. In some cases, ACEs are reported as soon as they occur, and in other cases, days or weeks after. So this information is based on the recovery at time of outcome, at time of reporting. So in response to your question, we did not find any pattern to associate with the reported outcome.
Thank you very much. One of the other comments in the Q&A block is, does the side effects or the adverse local reactions differ in different sites of injection, or is it only limited to deltoid? Is there any place that looked at administering in other sites and comparing?
Well, I will start with that and the others can complete. Well, as of now, we've mostly seen the reaction in the deltoid because it's adults that are mostly being immunized right now, and that's usually the vaccination site that is chosen. So it would be very in rare cases that the vaccine would be administered on another site. So maybe if one day children are being immunized in the thigh, we would see if it makes anything different. But with adults, typically it would be administered in the deltoid.
Thank you. Another question that is not related directly to the topic of discussion, but after receiving systemic steroids, I assume, how long should you wait before getting immunized? And whether that receiving systemic steroid changes the rate of those adverse reactions. It's not directly related to what we talked about, but if any of you has a sense of the answer, that would be good.
Well, I will start with that. And what I would say is usually the decision has to be taken with the clinician following the patient with a discussion with the patient. So based on the profile of the patient, the amount, the dosage of the steroid, they should decide what delay they need to apply, because what we want to avoid here is for the immune reaction to be blunted because of the steroid. And it should really be taken on a case-by-case basis when discussing the risk-benefit with your clinician. And also, I will refer to what was mentioned in the presentation. The NACI guidelines has a section on that about treating these patients whose immune system might be deficient, either because of a disease or because of the treatment they are taking. So you have recommendation on that in the NACI statement on COVID-19 vaccines.
Okay, thank you. Two questions on other comorbidities and whether they preclude or increase the rate of delayed reactions. Are those delayed site reactions more common in individuals who have autoimmune disorders or in individuals that had previous delayed response to another vaccine, such as the flu vaccine? Any information about that?
But I will start and the others can complete, but to my knowledge, the past history hasn't been described detailedly with the various information we've had, so.
Yeah, Jocelyn, I was going to say basically exactly the same thing. In fact, in the Moderna clinical trial, they really didn't even go on to describe those with the delayed local reactions in any depth, because it's considered to be self-limiting. So we don't really have a lot of information on those individuals who have had them.
Okay, so to summarize, a previous response to a flu vaccine should not preclude. I think that's what we're hearing, and we don't know if they're more common in other underlying autoimmune disorders. Is that a fair summary for the panelists, or someone has? Very well. If we've not been instructed or to report delayed injection site reactions, is there a process for collecting such a data, or is that open to any jurisdiction to accrue the data?
Well, I can start with that. As we mentioned earlier, you should follow the instruction in the jurisdiction where you are. And the instructions and criteria might vary from one jurisdiction to another, because the criteria are really based on the context and what people would like to follow as part of the passive surveillance. But like I said, if you feel you need to report, feel free to report the event, and it's going to be analyzed once it gets at the provincial or national level.
Thank you. So there's one question here about responses. So although you said, the panelists said that no prophylaxis is routinely recommended, is there any data that taking Tylenol or NSAIDs prior to immunization affects or decreases the chances of delayed response? I think I know the answer, but I wanted the panelists to try to address it.
I can take that. I don't think there's any evidence at this point to say using these medications prophylactically before you get the vaccine will help to prevent these types of reactions. So I would rather start to use them as soon as they start to develop symptoms than start them then.
Okay, and now to a more, I think we're coming close to answering most of the questions, so we'll take a couple more, and those are a bit more of philosophical and speculative. So what do you say about how would you encourage vaccine, and what would you say about the comparison between the vaccines in terms of educating lay persons, and then what do you think the role of those delayed responses are having on vaccine hesitancy? So it's a couple of open-ended questions. I'll give opportunity for every one of the panelists to say their philosophy about that briefly. Let's start with Rosaline.
Well, like I said, in terms of safety and related to local reaction in general were very common with all the COVID-19 vaccines that are currently authorized in Canada. So the safety profile is the same. These delayed reactions were mostly described as of now with the Moderna vaccine, but it doesn't make it less safe compared to the others. And that's the reason we are doing this webinar, to let people know that these reactions are benign. Because we know people might be less familiar with this delayed reaction. We are more used to having local reactions occurring immediately after the vaccine. So when they come like 8 days after, people can start wondering, should I be worried? Is it something serious? And well, we did the webinar to say it's not serious based on what we've seen to date. And also we wanted to make it clear that people should be careful not to consider them as cellulitis when it's not. So we're trying as much as possible to distinguish both.
Gina.
I agree with Jocelyn. I think the messaging is important here. We have seen delayed type reactions to other vaccines, but I think because this is such a mass vaccination, people getting vaccinated who probably haven't been vaccinated for years, for them to know that this type of reaction can happen, it doesn't put them at risk for that second dose, which is important. We don't want to have people hesitant to get that second dose. And that if we treat them aggressively with fairly benign medications, the analgesia, the antihistamines, the ice packs. We haven't talked a lot about ice packs, which is definitely helpful for these reactions. I think we can get that messaging to have the public more comfortable with these reactions. They won't be so surprised. And that certainly that message that it doesn't increase the risk of severe reactions. Certainly that message about severe reactions to the vaccines got out early to the public. So we want to make sure we separate out this is completely different than what that whole discussion was about.
Nosheen? Nushin, do you have anything that you wanted to add to this?
No, nothing to add. Thank you.
Okay, and Alyssa?
So it's similar take-home points, but I think they are important. These are rare. They're even less common with the second dose than the first dose. They're mild, they're self-limiting, and basically over-the-counter medications will treat them. So the hope is that this won't contribute in any major way to vaccine hesitancy, which, as Jocelyn said, is part of the purpose of this webinar.
Thank you very much. And a couple of questions that came in the chat about Moderna. So on Moderna vaccine, in terms of some of the side effects, are they related, or do you have analysis that is broken down by genetic background, ethnicity, or by the dose of the Moderna vaccine? Is it more common with the higher versus the lower dose? Or all the data we have is just from one dose that we're using in Canada?
I can answer to the data that we have in cases, as I mentioned previously. At the time that we extracted this data around the end of February, majority of cases had received first dose. Not everyone who received first dose had received the second dose. Maybe later on, the results of the analysis will be more meaningful. But for now, we can say that and we saw that over 90% of reports were associated with dose 1 of Moderna and over 70% dose 1 of Pfizer. But again, later on, when we have more information, we have more data, more reports, we can repeat the analysis to see if we still obtain the same result, more association with the first dose as compared to the second dose or not. That is just purely based on the reports that we receive in cases, and they are submitted voluntarily.
Okay. Any additional final concluding remarks? I think that the questions are now repeating themselves to some degree, so I apologize if we didn't cover all the questions in the chat, but we've certainly attempted to do so. Any final comments from the panelists? I'm opening this for all of you. Okay, if there are not any further comments, then I would like to thank Dr. Abrams, Dr. Amanipur, Ms. Afak, and Dr. LaQuesta for taking part in today's webinar. And thanks to the audience for joining us. We hope that the information is practical and helpful for your clinical practice. Today's webinar will be presented tomorrow again in French. And registration is available and open at nccid.ca. NCCID will continue to host Public Health Agency COVID-19 webinars to assist healthcare providers. The webinars on NACI recommendations and the new AstraZeneca vaccine will be held soon. And you can find more information at nccid.ca. The recording of slides from today's webinar will be available on our website, as I mentioned earlier. Just last thing, please fill in the evaluation for this webinar as it helps us to improve the products that we deliver. Thank you again, everyone, for joining today.